So, hello, my name is Dr. Ukiri Richard, and we are continuing our podcast on basic cardiology. Today, we are going to talk about exertional dyspnea and reduced exercise tolerance after a trip to Africa. The case we are going to use now is that of a 54-year-old patient that was sent to you because of symptoms of progressive shortness of breath. The patient is a male, has been well before now. He just recently had an official trip to Africa, and thereafter he has been experiencing exertional dyspnea and general weakness. He's not a smoker. There's no family history for heart or lung sicknesses. My question is, what additional information do you need in the history so that you could have a guide to the cause of the dyspnea and the reduced exercise tolerance? Well, the leading symptoms here is dyspnea. Because of that, we always have to think about the occupational history. And we have to look for history of what the patient has done in the past. Don't forget, pneumoconiosis is usually occupationally related. The pneumoconiosis or the dust gotten through inhalation of dust cause deposition of fixed anorganic and sometimes organic part of the bronchi, lymph nodes, and also parenchyma, long parenchyma. This can cause changes in the lungs. This can go with or without function disturbances. In a trip to Africa, you really have to take a travel history. You really have to ask if it was a malaria area, if he had a malaria prophylaxis. You have to look for history of an underlying infection, especially when the travel was to tropical belt, so that when you are doing blood tests, you will check for organisms that are not common in non-African regions. So you took the history and you found that the patient is an engineer that went for an engineer work. He never had exposition to dust. He traveled to Cape Town, which is actually a malaria-free region. The patient lived in a good hotel. There was no HIV exposition, and he never had any infection during the trip. In the physical examination, he had a BMI of 34.9. Blood pressure was normal. Heart rate 106 per minute. Rhythmic. There were no added sounds. There were no third sounds. Vesicular breathing. But the jugular venous pressure was elevated. We could not palpate the liver because of the obesity. There was very mild pedal edema, which is more on the right side and left. The respiratory rate was 20 per minute. So what technical tests are you going to carry out now so that your differential diagnosis of this dyspnea can be clarified? Well, I would like to do an ECG, chest X-ray, AP lateral, echocardiogram, and lung function test. What laboratory tests will you also request for? Well, I'll do full blood count, CRP, D-dimer, BMP, troponin, and blood gas analysis. So in the chest X-ray, the heart was just mildly dilated. There were some, strifed atelectasis on the right side. There were no pulmonary venous congestion and just mild pleural effusion right. In the ECG, sinus rhythm 106 per minute. QROS was 0.13 seconds and QT 0.42 with right bundle branch block. In the echocardiogram, you saw normal systolic and regional function. Right ventricle was a bit dilated. Left ventricle was normal. There were no left ventricular hypertrophy. Tricuspid insufficient. Had an elevated pressure gradient of 30 millimeters of mercury. In a laboratory test, CROP gives indication of if you have an infectious process. The full blood count give indication of infection, that is leukocytosis, of an asthma, a eosinophilia, of a chronic heart and lung pulmonary disease like polyglobuli. The D-dimer is for when you have lung pulmonary embolism is raised. BNP and NT-proBNP are elevated in case of heart failure. Troponin is usually elevated when you have death of cardiomyocytes. Troponin is not specific for an ischemia. In this our patient, CRP was 88, normal is below 5, had leukocytosis of 12 per nanoliter. Troponin was 0.06, that's elevated, normal is 0.032, and the dimer was also elevated, 11 millimeters per liter. The arterial oxygen saturation was 93% without additional administration of oxygen. The question now is, what additional test will you request for? Well, the dyspnoe with a raised D-dimer and a with the relation to a 12-hour flight will make me suspect a venous thrombosis and pulmonary embolism. So I will do a duplex sonography of the peripheral vein and request for a computer tomography of the thorax. Do you know the sensitivity and specificity of the duplex examination with when you are looking about venous thrombosis? Well, in 35 published studies with about 4,747 phlebography controlled patients, the medial sensitivity 95, specificity 97. In isolated 9 of the 35 studies, they were still also able to get a median sensitivity of 89% in lower leg thrombosis and a median specificity of 92%. These values covers that the diagnostic gap of the until now non-invasive methods in terms of underleg vein has been covered through the duplex sonography. Okay, you did the duplex sonography, where you saw that the patient had thrombosis at different levels of the right leg. Because of the until now gotten findings, you saw the indication for you have a suspicion of pulmonary embolism. Here you have backup from the history, laboratory finding, and echocardiogram and findings of the venous thrombosis. So my question is now, with all we have seen, it's very, very likely that this patient has a pulmonary embolism, and there's indication. First of all, you know that the patient has a venous thrombosis, so there's already an indication for anticoagulation. Would you still want to go on to do your computer tomography in this patient? Because how do you see the radiation load in the thorax computer tomography? Well, in high percent of patients with pulmonary embolism, through the examination, the thrombosis can be localized. For the diagnostic control, when you think patient has pulmonary embolism, that is okay. With the background that the acute therapy and secondary prophylaxis for patients with deep vein thrombosis and for hemodynamic stable patient with pulmonary embolism is the same, you can actually stop the plan to do a computer tomography. This is only when you have high suspicion in selected patients of a pulmonary embolism. The radiation load of the computer tomography of the thorax, according to records from German radiation Protection Office 2005 is between 6 to 10 millisieverts. But in this our patient, the computer tomography test is not desperately necessary. We just need to know if that striped atelectasis in the chest X-ray will regress after therapy. If not, we really need to do a chest X-ray to check if the patient has a central tumor. Okay, good. What place do you think echocardiography has in pulmonary embolism diagnosis? Do you know the parameters that you use to find out right ventricular dysfunction? Well, the right ventricular dysfunction can be defined echocardiographically in different ways. The criteria here are reduced wall movement of the right ventricle, right ventricular dilatation, disturbed or paradox movement of the interventricular septum, evidence of tricuspid valve insufficiency, regurgitation, and the estimated elevation, which can be calculated through the regurgitation of the pulmonary artery pressure, as well as the dilation of the or congestion of the inferior vena cava, combined or in combination. The named parameters, they have a high sensitivity for the diagnosis of a hemodynamically relevant pulmonary embolism, especially by combination background. You can also do a prognostic judgment of the disease progression. But don't forget that the specificity of these parameters are influenced in patients with already existing left ventricular pump function or a significant mitral valve disease. That means when you have underlying post-capillary pulmonary arterial hypertension and right ventricular pressure overload, these values could be low. Also, in overweight, pulmonary emphysema, and people with mechanical ventilation, the validity of these parameters is reduced. This our patient has an elevated troponin I or T. Do you think we have to do a coronary angiography for this patient, or does the pulmonary embolism justify the elevated troponin? Well, you have raised level of troponin I or T in 11 to 15% of pulmonary embolism, especially when there's a right ventricular dysfunction. If you do not have elevated troponin and also a normal BMP, these are excellent markers when they are not there for a benign progression where a consequent anticoagulation can be done. If in the echocardiography you have a normal left ventricular function and there are no risk factors for coronary heart disease, you can forget about the coronary angiography. Okay, my next question is according to the risk stratification, how are you going to handle this patient? Well, according to the values we have gotten, the patient is hemodynamically stable with right ventricular dysfunction. The stages of pulmonary embolism according to Grosser is GROSS is ERO. At stage 1, there is no hemodynamic effect and there is no pathologic arterial blood gas. Stage 2, you have mild hemodynamic effects. That means pulmonary artery pressure middle pressure between 50 to 20. And you have pathologic blood gas analysis with reduced PO oxygen partial pressure but above 60. Stage 3, you have hemodynamic effect with pathologic arterial blood gas with oxygen partial pressure below 60. And stage 4, you have severe hemodynamic effect, which means arterial hypotension shock. You have pathologic arterial blood gas, hypoxemia, hyper or the hypocapnia, and changed pH. In the treatment, according to the European Society of Cardiology guideline that was published, patients with high risk, they have a high mortality of above 15%. This patient, they have shock or hypotension, right ventricular dysfunction, and myocardial markers are elevated. In this patient, you do lysis or thrombectomy. Intermediate patients with high risk, either they have, no, this one they don't have shock or hypertension, but they have either right ventricular dysfunction and cardiac markers elevated, or only right ventricular dysfunction, you do an inpatient management. Those with low risk, without any of the above symptoms, you can handle on outpatient basis. So based on that, in this our patient, there is no indication for lysis, and anticoagulation is indicated. So until we have reached our therapeutic vision, you give heparin, either fractionated or fractionated heparin with controlled PTT. The mostly used anticoagulation here are enoxaparin, 1 mg per kg, tinzaparin, 175 mg per kg, or fondaparinux, 5 mg for patients below 50 kg, 7.5 mg for patients between 50 to 100 mg, and 10 mg for patients above 100 kg. In the lysis, you can use streptokinase, urokinase, or ROTPA, which is the recombinant tissue plasminogen activator. Streptokinase is given 250,000 international units at bolus over 30 minutes, which will thereafter be followed by 100,000 international units per hour over 12 to 24 hours. Urokinase 4,400 units per kilogram as bolus over 10 minutes, followed by 4,400 international units per kilogram per hour for 12 to 24 hours. If you want to use an accelerated scheme, you can give 3 million international units over 2 hours. In the ROTPA, you give 100 milligram over 2 hours, or 60 milligram per kg over 15 minutes. Maximum dose is 50 milligram. You give 0.6 milligram per kg over 15 minutes. Maximum dose is 50 milligram. So my next question is now, how long are you going to give this patient the oral anticoagulation with vitamin K antagonist? Well, because in this case we have a reversible cause of the thrombosis and the pulmonary embolism because of the long flight, and there is no malignancy disease, we can give the oral anticoagulation, which is an INRO of 2.5, between 2 to 3 over 3 months. My last question for you: how will you react if, as later, the patient developed continuous hypertension as well as hypoxia, which were associated with respiratory acidosis? How will you react? Well, the patient has moved to stage 4 according to the Grosser classification, and therefore in the high risk group for the European Society of Cardiology management. In this case, a thrombolysis is indicated and has to be carried out. Thank you very much.